This video touches on the topic of suicide. You might be coming to this video as a researcher or suicidologist who engages in this subject matter in your work, as a survivor of suicide or suicide loss who has been personally impacted by this subject, or as a policymaker looking to translate research into policy. However you're showing up today, the topic of suicide can evoke a deep pain and emotion. Before we begin, I'd like to start with a few grounding reminders, borrowed from Dr. Jeffrey Anslus. You may want to consider checking in with yourself to decide how and when to best watch this video. Maybe you want to watch it with other people. Maybe you want to watch it in the morning and not late at night. We invite you to bring a good heart, a good mind, and a lot of compassion for all as you watch, including yourself. Feel free to take a moment now to pause, reconnect with yourself, and reflect on how you plan on engaging with the content today. There are resources available to you should you want to talk to someone. Depending on where you are in the world, those resources may look different. In the description of this video, we've provided some places to start, with options to get help for yourself and help with supporting someone else.
So like I said, this is the third installation of our Methods Core seminar series, All Hands. Our previous seminar was covering meaningful research engagement with Anna, DeQuincy, and Julie. If you did not have a chance to watch that, it was absolutely fantastic. There are 3 different ways you can access it. So if you're in our base camp, you can access it through this announcement that's in the HQ project message board. You can also go through our SharePoint following this file path here. And if you're not in our Basecamp or our SharePoint, it's also on SCRC's YouTube. So you just search UW SCRC and you can find the link. There's actually a whole playlist of the Methods Core seminar series. And I think the meaningful research engagement segues super nicely into, as you're thinking about how you're engaging folks in your research, you also want to be considering how does that engagement fit into your methodological framework. So I'm going to pass it over to Kelly and Andrea to set that up for us here at SCRC.
Andrew, do you want to get us?
Sure. Okay. Welcome, everybody. Good to see you. I know I'm excited about this topic, and Kelly and I had a lot of really great conversations to prepare this for you. So we're going to talk today about human-centered design methods to achieve the preparation phase goals in the multi-phase optimization strategy framework. That is a lot of words. And bear with us. We're going to define these and we're going to share some acronyms and talk you through what this means. But first, we're going to introduce ourselves. Kelly?
Sure. So just a really quick, I think I know most of you, but just wanted to quick introduction. So my name is Kelly Rulison, and my training is in prevention science and methodology. A little kind of bit of background, I was a faculty member for 10 years in the public health education department at UNC Greensboro, and then 3 years at Penn State in the human development and family studies department. But I left academia in July to work for a small research company called Prevention Strategies, and we focus on developing, evaluating, and disseminating prevention programs. I live in Pennsylvania, so it's lunchtime here. I know it's morning coffee time on the West Coast, but we're gearing up for lunch here. And I live here with my family, my husband, Mike, and I have 3 kids, Thomas, who just turned 3 a couple weeks ago. I have a 7-year-old Michael, and my daughter Emmy is 5, but she likes to tell us she's counting down the days, beginning of May. Everybody around here knows exactly which day in May is her birthday because she's counting it down until she turns 6.
That's great. Yeah, I'm Andrea Hertzler. I've had a chance to meet many of you, but great to meet all of you today. I'm a professor in the Department of Biomedical Informatics and Medical Education in the School of Medicine at the University of Washington, and my training is in biomedical informatics. I focus on human-centered design. I have a strong interest in health equity, and using human-centered design to promote health equity through engagement of users or people that use technology and informatics, intervention services and products. And so I've had a pleasure to work with a lot of you on the DDBT framework for human-centered design that we've adopted in the center. This is, I have a 24-year-old son and my partner, Sean, and this is us touring Japan last summer. My son's actually there teaching English in Hokkaido in a fairly rural area. We went to Osaka, and that's Osaka Castle in the background, over the summer to visit. So that was a lot of fun. And without further ado, why don't we jump in? Our learning objectives today are threefold. First, we're going to identify the goals of the preparation phase of MOST, the multi-phase optimization strategy. And we want you to walk away being able to explain the link between MOST and DDBT within SCRC's methodological framework. I'm just giggling over here with all of our acronyms. DDBT, that's design, or rather discover, design, build, test, our human-centered design framework. And of course, we all know SCRC. Third, we want you to walk away being able to apply a MOST and DDBT lens to develop or revise your conceptual model for your project. And I'll hand it over to Kelly.
All right. So the first part of our presentation, we're going to look at how to link DDBT and MOST within the framework. So, most of you are aware that MOST is the one of the guiding methodological frameworks in the SCRC, and it has 3 phases. So the preparation phase, the optimization phase, and the evaluation phase. And I'm not going to spend too much time today going through these phases. I put together an asynchronous seminar about MOST that many of you may have seen, or if you want to find out more about MOST, can watch that. But I do want to briefly talk about the goals of each phase of MOST, just as a way of reorienting us to what we're trying to do here with this multi-phase optimization strategy. So in the preparation phase, we're essentially trying to determine what needs to be in the intervention. We're going to create the intervention and then perhaps do some pilot testing. And so that boils down to a number of different goals of what we're trying to achieve in that preparation phase. So the first is developing a conceptual model. And we're going to go into more detail about this a little bit later in the presentation. And we are trying to use that conceptual model and also some other work that we do to identify and create a set of candidate components to include in the optimization, or to include in the intervention. Then we need to do some pilot testing. And finally, we need to identify an optimization objective. And I just want to say a real quick word about this, that even though we often use the word optimize kind of colloquial, we want to create optimized interventions, it does have a really specific meaning in MOST, and it kind of helps to have that in the back of your mind as we're going through the rest of this presentation. And an optimized intervention is one that balances intervention effectiveness against intervention affordability, scalability, and efficiency. So we're trying to do that when we get to this optimization phase, which is the second part. And just kind of to give some examples to have them in your head, some potential objectives are things like we're going to have all active components. So all components we're going to include in the final intervention if they're working. Or maybe we can only create an intervention that has a set of the strongest set of components that we can implement within 15 minutes or within a certain amount per person. And so in order to determine that, to figure out what intervention can meet those criteria, that objective, we have to move into this optimization phase. And there the goal is to identify an intervention that meets that optimization objective. And then we assemble that intervention and we evaluate it in the evaluation phase. We test that final optimized intervention package. Okay, so those are what we're trying to do within each phase of MOST. But the next question is that okay, but how do we actually carry out each phase of MOST? The evaluation phase is actually pretty straightforward. It uses all of the standard evaluation approaches. There's lots to choose from that we evaluate interventions typically. You often use like a randomized control trial where we compare our optimized intervention that we've created earlier in the most process against maybe a waitlist control or a usual practices condition. Or we conduct things like a hybrid implementation trial. So lots of different ways that we can carry out this evaluation phase. Within most, there's been a lot of focus on this. How do we actually carry out the optimization phase? A really common design is the factorial design to evaluate the effects of each of the individual intervention components. But other approaches are also possible. Using SMART trials, for example, if you've got a adaptive intervention and trying to evaluate that. But in the preparation phase, there's been, until recently, it's kind of been left open within the most literature about how do you actually carry out the preparation phase. Most of the work has been on the optimization phase and what actually needs to occur there. And it turns out that there's kind of growing recognition that using HCD frameworks such as DDBT are ideally positioned, and we're going to talk about that more here. They're ideally positioned to meet the goals of the preparation phase of most. So kind of pulling all of this together leads us to a slide that you've likely seen before, with just a slight adaptation here in the title of it. Most of the time, this title just lists both of the frameworks. And as Andrea and I really worked through this, it seems like a slightly better way to put it is that the methodology that we're using here in the SCRC is the most framework, with using the HCD, specifically the DDBT framework, as the approach to actually complete the preparation phase of most. So we've got here our specific phases that we're trying to go through with most. And down here are the specific ways that within the SCRC that we carry out each of the phases. And so if you look here, HCD, specifically DDBT, is how we're carrying out the preparation phase of most. I'll turn it back to Andrea to walk us through a little bit more before we're going to bring them back together, most and DDBT, but Andrea's going to walk us through a little bit more background on DDBT.
Great, thank you. Okay, so how do we think about design or discover, design, build, test DDBT embedded within most, right, as our methodological approach that how do we achieve those 4 goals? So just to bring us back, just a quick reminder that DDBT draws on principles of human-centered design. It's not the only way to do human-centered design. It's one particular framework it's a great one to inform system development. Some of the principles that are really important is that we do participatory engagement of users, people that are impacted by this system. And we use a range of different methods. There's not just one way to engage users to inform the design. We bring curiosity. So we don't come with knowing exactly what we're designing, but we come with a curiosity to learn from the people that are going to be using the system and allow that to drive design. So open curiosity is important. So is iteration. So learning and iterating, trying and seeing what works, what doesn't work, what sticks, and refining over time. So iteration is important. And we also have a focus on improving system usability, feasibility, and acceptability. These are really important because you don't want to put the money, effort, and time into building an expensive system that you don't know is going to be usable, feasible, or acceptable. And so the focus here for DDBT is really on those proximal outcomes to ensure that you've got a really solid design that's going to be usable, it's going to be feasible, it's going to be acceptable because you've got data to demonstrate that. You're going to put the time in now to move on to some of those later phases in most, and not worrying about these outcomes, ensuring that you can count on this. Next slide. Oh, actually, let me go back and I just wanted to point out, if you haven't seen Lucas's great asynchronous seminar to learn more about DDBT, I call out to that. And there's at the end of the slide deck, actually, and there's a link right here to that talk. Next slide, please. So let's focus in on that first phase of DDBT, the discover phase, because that's really where we're going to focus today, and its connection to conceptual models in the MOST framework. So the purpose of the discover phase is to define user needs and context of use for this future system. And again, by system and SCRC, what we mean is not necessarily, a digital technology, but it's actually the intervention, service, or program that you're designing. There may be a digital component, but there might be training components and paper components and process components. So that whole package is what we're talking about when we mean system. The two things that we talk about are user needs and context of use. What the heck does that mean? Well, first of all, we need to know who are the users of this future system. That's a really important question to be asking in the discover phase. We use the word user a lot. Not everybody likes that, but if you have other ideas for a better term, share those with me. We, open to it, working with the language. But typically when we say a primary user, this is the main person who's going to be interacting with the system you're designing. Okay, the secondary users may access a subset of functionality. So let's say your primary users are youth. A secondary user might be a clinician, might be a parent or a caregiver that might be accessing a subset of functionality, maybe to set up programs or monitor data submission, those kinds of things. So they do need access to a system, but they're not a primary user. Hopefully that makes some sense how we distinguish that. And there may be other engaged individuals who are impacted by the system. So we can think of those as tertiary users. Maybe they don't interact with the system explicitly, but their workflow might be impacted. You can think about clinical staff, where there may be a workflow issue with a system that's having a negative impact on their clinical workflow. These are tertiary users, and it's important to kind of have a sense for who are all the users, the people impacted by the system. Once we have those groups identified, then we can go on and really focus in on what are the needs of those users. What can't they do now that they need better support in the future from this system to be able to do? So in human-centered design, we often focus in on tasks. What do they need to do? What's the functionality that the system should be supporting? Okay, as opposed to what color do they like, aesthetics and things like that. Those become important later on, but that's not where you want to start. You really want to start with a functional view. What are they trying to do that they can't do right now? What is that workflow blocker? What are the barriers? So contextual factors. So these are looking at the environmental factors, right? In what context are your users using the system? So going back to our example of the teenager, if the teenager is a primary user, they may not be using the system in the clinic. They might be using it at school or at home. Their context of use, the environment in which they're using the system, is the home or school environment, largely, 99% of the time. A clinical user, their tertiary user might be interacting 100% with the system from clinic, from work, right? So those user groups have different context of use. And it's important to recognize that, because the context in which someone's using a system is going to carry barriers, right? There's going to be barriers, there's going to be facilitators. There's also going to be constraints. So these are barriers that you can't change, right? That you need the system to work around. So it's really important in your discovery phase, to answer these three questions. Next slide, please. Okay, so, just wanted to quickly say that oftentimes we'll call this a needs assessment, and just want to point out that needs are a piece of this. Context of use is important, but oftentimes it goes shorthand needs assessment to cover all three of these bullets. Next slide, please. Okay, wanted to just share some example research methods that you can use and discover. Again, there's not just one research method for this to collect and analyze data. These are largely data collection methods that I have listed here: interviews, group interviews, surveys, contextual observation, going into the environment in which the system's used and watching. So not just asking people their subjective perspectives, that's important, but also watching what people do when confronted with a system or in their natural environment. These two things sometimes can conflict. So it's important to watch and listen to what those needs are. Diary studies. People can talk about what they do in their day-to-day life, give you a view into their needs. Technical probe studies. This is you throw an existing system at someone and you see, you have them use a system and learn about what doesn't work, right? There's a lot of different things that you can do to understand who are the users, what are their needs, what's their context of use. Envisioning is another thing that my group has been doing more, using film. So being able to present a film with a system and how, have people explain what is the function of this system in this film. So there's a lot of different methods. Some of them are a little bit further out there, but all of these are really the purposes to understand who are your users, what are their needs, and what are their contexts of use, and different ways to have that conversation or learn through observation. Next slide, please. So we're going to talk about now, kind of just did a overview of DDBT. Let's talk now how I'll hand it back to Kelly on how we link this back to MOST.
Yeah. So we're going to just on this slide kind of show you, we went over at the beginning some of the goals, or what the goals of MOST are, and let's see how those map onto specifically onto DDBT. So the first two goals can be done as part of the discover phase, so developing your conceptual model and identifying the optimization objective. And actually developing the conceptual model often begins even before you start the DDBT process. You may have a draft model that you started as you write up your grant proposal that's kind of driving part of the work. You may not know what components go in the conceptual model, but you may know parts of that model. We'll talk about that more in a minute. But you might use the discover phase to go back and revisit the conceptual model and to figure out how to best implement, so what components are needed and what those components need to look like in order for the intervention to work. So basically, you're going to use the results of the discover phase to help you figure out how to implement the components, which is then carried out as part of the design and build phase. So in that design and build phase is when you develop and revise the set of candidate components using information from your discover phase. And then you move into your test phase, where you accomplish the last goal of MOST, conduct pilot testing. You pilot test the intervention itself. But you can also be pilot testing some things specific to MOST. For example, the research protocol, research design, if you're going to be carrying out a factorial design, and it might be really important if you're going to be having clinicians carry out your the different conditions for your optimization phase. You may want to test whether they can successfully see a participant come in, randomize them to a condition, and figure out what specific components they need to implement with that person, with that patient. So you might be testing some specific parts of MOST. And so, when Andrea and I were putting together this slideshow, we realized that we could spend a lot of time on every one of those, each one of those, and how we link DDBT with meeting each one of these goals. But because we didn't have 4 hours to put this presentation together, what we decided to focus on was just linking using the discover phase to work on developing that conceptual model. So just to illustrate how we can use the discover phase to meet this goal of developing the conceptual model. So moving into the second part here, we want to specifically focus on how to use DDBT to meet that first goal, developing a conceptual model. So real quick, a conceptual model is, when I'm talking about it here from the MOST framework, we're talking about a model that describes the process of change, how the intervention is expected to work. So once we have a completed conceptual model, we read it from left to right. We've got our intervention components. We look at what each one of those components is expected to do and how those, what those targeted mediators or proximal outcomes, what they are expected to change over the long run toward our eventual ultimate outcome. But to develop a conceptual model, we often work from right to left. So we start with the ultimate outcome that we're trying to achieve. So here, a big focus within the center is, preventing suicide or suicide attempts. And so that might be the ultimate outcome of many of these interventions. And then we want to work backwards from that, look at the literature to figure out, look at empirical and clinical insights about what are the risk and protective factors that lead to that ultimate outcome. For example, we know that suicide ideation is a strong risk factor for suicide attempts. So that might be one of the distal outcomes that we want our intervention to try to address. And yet targeting that directly is not something that we can do. We need to figure out, well, what leads to suicide ideation? Are there factors that we can actually change or target as part of the intervention? And that's what our targeted mediators or proximal outcomes are going to be. And so just kind of putting it together, this right side, these last three boxes, are often determined from the empirical literature and from our clinical experience. And like I mentioned, they're often done before you actually start this whole process. You've looked into the literature and have some sense of how, what you're trying to target, what you're trying to change with your intervention, and how you might want to get there. But it can be used to inform the discover phase. And we're going to use an example for you to see that. And this, as most of you know, a conceptual model is never set in stone. It's kind of a guide. And that's the case here. It can be used to inform the discover phase, inform what we need to, knowing what we want to target can help us figure out in the discover phase or during that needs assessment, trying to figure out what the components actually need to be, or also what needs to be included in those intervention components. So how are those intervention components actually going to be implemented? So really briefly, we wanted to just kind of walk you through an example, and we thought that the example that from the article, the O'Hara et al. Article that Lucas had sent out, that really walks through, is great. If you haven't had a chance to read it, it's a great description of how HCD can be used, or DDBT specifically can be used to accomplish the preparation goals of MOST. So in that, they use an example of an intervention for children post their parents are either going through separation or have become divorced. And so they talk about the problem that they were seeing and observing is that many of these children are ending up coming into clinics with various mental health problems, and that's what they're trying to change. And through their literature review before they kind of start the process, one of the risk factors that they identified were maladaptive responses to interpersonal conflict. So when children had those maladaptive responses, they were more likely to experience these mental health problems. And so again, looking in the literature, they identified a number of different factors that can lead to those maladaptive responses, or reverse that, having these skills. So for example, having reappraisal skills, being able to look at a situation and move past the negative emotions, to try to see the situation more objectively. Kids who had those skills were more likely to have adaptive responses in face of that, as they face that interparental conflict that they were going through. Same thing with identifying distraction skills and relaxation skills as important coping skills. So they knew, kind of going into it, that they've got, this is the right side of the model that they have at the start, and know what they want to target. Not really clear, you know, when they start, as they're going into the discover phase, well, exactly what components should we have that target those? Is there anything else missing? And how should we do those things? So that's kind of where they went, kind of going into into the discover phase. I'll turn it back to Andrea for a minute.
Sure. So again, take a look at this paper. It's a really great example. And let's talk about how O'Hara may have gone. We'll have to embellish a little bit because they don't have all the details. There's a lot of details, but let's talk a little bit about how they might have talked about how to implement those components. So the key stakeholders, and I think we want to get away from the word stakeholders because that can historically that doesn't feel good, that term. So I think another term that I've started to use is engaged individuals. So those key engaged individuals or user groups that were identified by O'Hara were children ages 9 to 12. These are our primary users who experience high interparental conflict. We also have our secondary users. These are the parents or guardians. And then what we can think of as tertiary, the other group that's impacted by the system we're developing are the family court professionals. Okay, so that's our first question from the discovery phase. Who are our users? And from this article, we know that they've identified these three groups. They then talked about how they engage on these different groups in interviews to be able to explore what their needs and context of use are. Okay, and this is where I've embellished some. So let's say through these interviews, we have some findings, okay? And I'm just going to focus on children, our primary users in this box on the top row, and parents or guardians on the second row. So let's say that the findings from these interviews pointed to, for children, our primary users, that they wanted to learn more about divorce. They wanted to learn how to cope. Okay. So again, I just want to remind you that what do they want to do better with support of the system? What's the functionality the system should support? They want to learn and they want to cope, are the tasks, right, that they want to do. And so in the article, we know that reappraisal, distraction, and relaxation are important coping skills for the intervention, okay? So we can learn from the interviews some of the things that I've embellished and thought maybe a child, or maybe one of the children said, or maybe there was consensus, and many of them said, I'd like to talk things through in private, you know? So we can start to think as we get into the design and build phase, statements of need like that might point to functionality like a chatbot, or maybe something not quite so tech heavy, you know, maybe a conversation with somebody to practice those reappraisal skills. Distraction, maybe there was consensus around video games, videos and games that help me feel better. Maybe through the interviews, you're hearing things like this. So when we start to get into design and build, does this point to functionality like gamification that might be really appealing to these children and keep them engaged? Maybe there's other strategies for distraction. And then relaxation, maybe there was some talk about how I need help calming down. You know, this is related to relaxation and coping strategies. Are there ways that we can use mindfulness strategies and implement them into this intervention, right? So these are not so much the what, but they start these expressions of needs that come out of these interviews that I've embellished and made up. Hopefully I'm illustrating how these start to lay the groundwork for how you can begin to think about needs and having that be the foundation for what you go on to design, rather than deciding what you're going to design first, but really having those needs drive the design. Context of use is another really important piece, as we've talked about. So thinking about the setting, you know, where did kids talk about wanting to learn about divorce and doing some coping skills? Again, probably at home and at school. They probably didn't want to go to the clinic for all of this. Who knows? I'm embellishing again. It's important to ask, you know, about where do they see themselves doing these tasks. They might have talked about being more likely to do these kinds of things if it, you know, took maybe 30 minutes or less. That was in the paper. And they might be less willing to use if the parents can see everything. We often hear this from kids, right? So this idea of having some privacy, having some, you know, some space within an intervention where they can feel like it's their own. I'm not going to take the time out for the parents, but you can read that and kind of explore the implications for design there. And next slide, please.
Yeah, so you want me to go ahead?
Yeah, that'd be great.
Yeah, so just to kind of bring back to that conceptual model and look how, if those are the findings, what you come out of from the discover phase, you can see how we can use that information to kind of finish fleshing out the conceptual model and actually changing it a little bit. So this is the same conceptual model mostly on the right as before, but notice that we've added what are the targeted mediators with information about divorce and brain science. So that came from what the children and parents were saying that they wanted to see as part of that. So they may not have originally had that in the conceptual model, but you hear that, or they did, or you may hear some things. So you may go in knowing, okay, these are the important factors that need to be in there, but there may be other things that need to be in order for your users to actually engage with the intervention. They may need some other pieces as well, besides the pieces that you're trying to target. So that might get added. This is a way that the discover phase can help you change or revise that conceptual model. And then you can see that then the left-hand side is now filled in with actual intervention components. So we knew before about that we wanted to target the reappraisal skills. And so we're going to add a component that's going to specifically do that. And this is kind of, and then an educational piece that's going to be added to present that information about divorce and brain science. And then one of the important pieces that came out as Andrea and I were discussing this is that, you know, this tells you a lot about when you're developing this conceptual model about what needs to be in the intervention. But the really important piece that comes out of that discover phase is really the how. How are we going to? So we know that we want to include that reappraisal skills training, but what is that actually going to, how is that actually going to be done? And through our hypothetical, maybe it's going to be done with some type of chat box. Or the distraction, maybe that's going to be done with the gamification. So how these are actually going to be implemented, these components, will be more the focus of the design and build as you're moving from discover into the design build phase. But you're going to continue focusing on these components and actually what is going to be included in them and how you're going to actually carry out those. Okay. So that's just kind of one example of how you can use the conceptual model. You start with it before you go into the discover phase. It helps you guide some of the questions that they may have asked to get to. You know, if they know that they want reappraisal skills in there, a question that could have gone into the interviews and focus groups is really probing questions to figure out, well, how is that best going to be done, to be able to figure out what that component looks like. Okay. So for the rest of the time, we thought that it would be really helpful to give you a chance to sketch out your working conceptual model. I'll let Lucas in a minute talk us through the Figma board process of how we're going to do that. We're going to put you into breakout rooms for each of your research groups so that you can work together on your conceptual model. You may already have that. And if you do, you can start thinking about what the gaps are. What do you still need to figure out, or what You can use the model to brainstorm what additional information you might need from users about their needs and their context of use. So if you know the what, you already know the components. Do you know the how? Do you know how those components are going to be implemented? Or do you need to find out more questions about that? And if you've already gone through all of this, then really kind of going back and reflecting how the information that you learned may have helped you get to that conceptual, or any kind of notes about how you revised your model in response to the feedback. And before we do that, I just want to show you real quick, kind of, if you haven't done this before, just think about how you develop your conceptual model. It's really best to start with your outcome, even though in the end we read them left to right. It's really best to start with that ultimate outcome, what you're trying to do. Think about the risk factors that are predict that ultimate outcome, and think about the proximal outcomes that lead to those distal outcomes, and then figure out whether you know the intervention components already, or whether that's something that you need to go into the discover, figure out. I don't know why it got automated, sorry. You may have to go into the discover phase to try to figure out. Okay. All right, so you can start with this and kind of work backwards, but I'm going to let Lucas kind of jump in. And I think maybe just 5 or 6 minutes in groups, just a short bit of time to kind of talk, because we would like actually to kind of hear people talking about what they're struggling with this, what kind of questions they have. So a few minutes to talk with your group, and then maybe we'll come back here to the full group to kind of do a share out. So Lucas, do you want to?
Yep, I'm going to steal the screen sharing. I've set the breakout rooms to be for 6 minutes. Are you all seeing the Figma board right now? Okay, awesome. So it's got a bunch of things in here. There's a section for each team here, or for almost each team. We kept out the WISE path one because we'll break up the folks that are in that. If you want to see just the blank template, it's over here. The example one from the O'Hara paper is also included. And then I pre-populated for each of your teams. If you already have a conceptual model created, information is already added, and I've got comments to some of the teams in here as well. For folks that have not or are less familiar with Figma, there are also some quick tips for just navigating on the side for each of your screens. So I will share the link in the chat. And then I'm going to open up the breakout rooms.
I bet Lucas will show up.
I'm back.
The recording, and it will get a notice recording in progress every time you join. It's really
I'm sorry, that's distracting.
That's okay. We were trying to figure out, why does it keep doing that? And it was following you around. It's interesting.
Good to know. Good to know. I will definitely edit that part out.
Oh, that's fine. It's technology probe example right there.
There we
Throw
go.
out a technology and see what happens and what problems come up.
I wonder if there's a way that we can replace it with the Lucas theme song of some sort instead of recording in progress.
Love it.
Yeah. So now that you've had a chance, I know it was a really short chance to kind of be thinking about, but maybe either from this or things that you've been working on, it'd be great to hear either examples or questions that you guys are struggling with as you try to figure out how to use the DDBT, specifically the discover phase, in developing your conceptual model. Are there challenges, questions, successes, right? I'm looking for successes for myself. Like how are people making it work? Because I'm really interested in how these can be combined. So anything that people want to share, or Andrew, I don't know if you have any thoughts either.
Maybe just some space for folks. Reflections. You could put them in the chat window.
I'll just reflect that we had, in terms of successes, I think we were we've been mostly thinking in the middle and back. So I think we've made a little progress in terms of how do we distinguish an ultimate outcome from a distal outcome? So thinking about, in our case, the recovery from suicidality is our ultimate outcome for the STRIBE study, and that makes the distal outcome reduction in present suicidality, right? If we're bringing in AYA folks who are currently experiencing suicidality, then our distal outcome. But
Kelly,
really what we're trying to do is prevent recurrence and chronicity. So I know at the recent suicide conference, there's folks who are now working on recovery-oriented measures for suicidality, and so we're going to check those out and see there may need to be some measurement around chronicity and recurrence for suicidality that we need to capture that ultimate outcome.
I think this is a really important point, Kate, that you're bringing up about the process of this conceptual model, and something that Kelly and I talked about is which direction do you go? And I think where we landed was it's really hard to design something when you don't know what those outcomes are. And you may end up in a completely different place that you don't want to be in. If you're on solution, sometimes we'll call that solution jumping in human-centered design. And so really starting and grounding it in those outcomes and going from right to left can be a really great strategy. And that's what I just heard, Kate, as you talked about your process, getting really clear on that.
And I think when Andrea and I were talking about it, I think even for those of you who are starting with a tool that you're going to adapt to try to, maybe it's been used in other contexts or to target other behaviors or other populations. And we talked about that there's still a lot of benefit from starting with that right hand side and working backwards. And you kind of know where you're going a little bit as you're working back, because you know, but that can also help you figure out if there's gaps, which I know some of you are trying to figure out, like, is the current existing tool, can we just adapt what's there? Or are we going to need to add some other pieces? Because you might say, all right, for what I'm trying to end up with, this is a really important piece of my model, and nothing here in the existing model can be, or the existing tool can be adapted to reach that. So maybe I need to add something, or it might help you see, okay, I can align these. I know what I want to do. And then maybe this is the piece, the chatbot feature that already is there. It's best used to target this part of my component or this part of my conceptual model. So there's still a lot of benefit, even if you kind of think you know what the components are that you're going to work with, from still starting at that right-hand side and working backwards so that you don't miss anything that should be there and it's not.
You might need to drop a piece of functionality that isn't connected. That's not necessary. That's, when you're adapting.
Yeah.
So add, remove. Yeah. So Lucas says, Lucas, where are you? Oh, there you are.
Yeah, I was just saying the value of, even if you have your conceptual model built, continuing to return to it, both because the research activities are going to continue to inform it, and then also we're human beings and we're engaged in activities outside of the single research project we may be focused on for that conceptual model. So events that we attend could further inform it. If you're anything like me, just having it in the back of your head while you're eating lunch or showering, you might get a new set of ideas. So building those in and just continuing to keep it as a stake in the ground conversation as you move through the project process.
I'd also just want to reflect on how a lot of these design principles really have not been sort of they're trying to do systematically what a lot of psychologists who've been developing evidence-based practices I think have sort of developed organically. Like a lot of folks who created DBT or CAMS or CBT or whatever, there was sort of an organic process as people spent hours and hours and hours doing therapy and figuring out what worked and what didn't. and thinking about it from a design point of view, there's words for things, there's ways to label things that people are doing. There's ways of being systematic that I think are, I think of it as a little bit like validation in DBT. If you're doing great with a patient, you and the patient are getting along, you probably don't need it at all. And if you're stumped, if you're stuck, you need to be able to specifically label what are you doing, where are you stuck. And I think that sometimes perhaps that's how some of these interventions that have been developed for suicide are too big. For instance, is that they do, they're not optimized. Things were not developed with this sort of design and optimization frame. So I really am appreciating that there's a sort of clash of like, there's moments when I'm like, this is what I do. I do treatment development. Like, this is sort of boxing me in some ways. And in other ways, I feel like as we've been going through this process over the last year, realizing that like part of this is language and thinking about what people call things differently, and also just being more systematic about things that I think are more organic, often in suicide treatment and development in this area.
Yeah. I'm going to jump in just because we're 1 minute over time and just say thank you, Kelly and Andrea. Our May installation of the seminar series is going to be with Kevin and Andrew, covering some of the developing pre-specification of analysis plans and some of those quantitative approaches to the suicide care pathway research. So stay tuned. Look forward to next month's seminar, and thank you to Kelly and Andrea.
Yeah.
Thank you, guys. Thanks, Lucas.
Thank you for watching this seminar from the University of Washington Suicide Care Research Center. Please take a moment to complete the anonymous evaluation to share your feedback. If you would like to receive a certificate of completion, be sure to also complete the attestation. Links to both surveys are available in the description of this video. Your input is much appreciated.